Hello and welcome to the first NCCN Global Policy Webinar of the year, The Growing Cancer Burden in Young Adults. My name is Katy Winckworth-Prejsnar. I'm the director of the global program here at the National Comprehensive Cancer Network, and we're so glad you could join us today. This is a timely and important conversation. We know that recent data shows significant increases in cancer among young adults, with early onset cancers rising across at least 14 types of cancer. For young people between the ages of 15 and 39, these trends call for much more attention, not only to prevention and treatment that reflect their specific needs, but also to policies required to address this changing picture of cancer worldwide. Before we begin, I would like to briefly introduce NCCN. NCCN is a not-for-profit alliance of 33 leading academic cancer centers, all working towards the same goal: improving and supporting quality, effective, equitable, and accessible cancer care. Drawing on the expertise of clinicians across our member institutions, NCCN develops resources used throughout the cancer care ecosystem, most notably the NCCN Clinical Practice Guidelines in Oncology. These guidelines provide evidence-based recommendations to support high-quality cancer care for providers and patients worldwide. The current NCCN Guidelines library includes 91 guidelines with more than 237 algorithms covering approximately 97% of global cancer incidences worldwide. In addition to disease-specific guidelines, NCCN also publishes guidance on supportive care, detection and prevention, risk reduction, and population-specific needs, including the NCCN guidelines for adolescent and young adults. These guidelines are always available free of charge on nccn.org and through our mobile application. I also want to highlight a relatively new initiative from NCCN, the NCCN Guidelines Navigator. This interactive digital tool converts the static PDF guidelines into a format that's much easier to navigate and search. It's designed to help users find the information they need more quickly and easily at point of care, and it's also available free of charge on our website. Another important resource for young adults facing cancer are the NCCN Patient Guidelines for Adolescents and Young Adults. These guidelines are designed to provide people affected by cancer clear, easy to understand information about diagnosis, treatment options, and supportive care needs. They also speak to many of the issues that are especially important for adolescents and young adults, including fertility, mental health, navigating treatment, and survivorship. We encourage you to share these resources widely with individuals with living or lived experience, caregivers, and community organizations. Looking at where NCCN guidelines are downloaded, we know they are used worldwide. Nearly 1 million registered users access NCCN resources from outside the US, and last year alone, more than 7 million guidelines were downloaded internationally. As this heat map shows, NCCN resources support practitioners in nearly every country around the world. We'd like to recognize and thank the supporters and sponsors of this webinar. Your collaboration makes programs like today's possible, and we appreciate your commitment to advancing equitable cancer care worldwide. Today's program focuses on a troubling and fast-growing issue, the rising burden of cancer in young adults. We're seeing a significant increase in early onset cancers, and that trend is accelerating. To put that into perspective in numbers, people born in 1990 are now about 4 times more likely to develop rectal cancer, and more than twice as likely to develop colon cancer as those born in 1950. Colorectal cancer rates are rising in younger adults, even as they begin to level off in older populations. And it's not just colorectal cancer and rectal cancer. More than 10 other cancers, including breast, uterine, and kidney, are also increasing in people under 50. These patterns reflect a complex mix of factors, including environmental exposures, lifestyle changes, and broader systemic issues. To help us better understand what's driving these trends, we'll begin with a presentation from Dr. Bennett Caughey, who will share what colorectal cancer trends can teach us about changing cancer risk in younger adults. Then we'll hear from Dr. Omalalo Salako, who will focus on delayed diagnosis and inequities, particularly the challenges and risks facing young adults in low-resource settings. After that, we'll move into a live panel discussion to dig deeper into these important issues together. We're honored to have Dr. Renuka Iyer, Chief Medical Officer here at NCCN, moderating today's session. Dr. Iyer joined NCCN in February, and we are thrilled to have her leadership and expertise. She came to NCCN from Roswell Park Comprehensive Cancer Center, bringing deep experience in oncology and a strong commitment to advancing high-quality cancer care globally. I'd like now to briefly introduce our keynote speakers. Dr. Bennett Caughey is a medical oncologist at the Mass General Brigham Cancer Institute, specializing in gastrointestinal malignancies. His clinical and research work helps illuminate the shifting epidemiology of early onset colorectal cancer and what these trends mean for young adults. Next, we will hear from Dr. Omalola Saloko. Dr. Saloko is a consultant clinical oncologist and senior lecturer at the University of Lagos and CEO of the Sablekli Cancer Care and Support Center in Nigeria. Dr. Saloko has authored more than 70 peer-reviewed publications and works at the intersection of epidemiology and digital health to improve early detection and reduce diagnostic delays in low-resource settings. She also serves as the co-chair of the research subcommittee for the Nigerian Cancer Society and was recently named one of the 100 most influential global oncology CEOs of 2025. Both keynote presentations are pre-recorded, but they will be able to address your questions during the live panel discussion, where they will be joined by an esteemed group of international thought leaders in this space. We look forward to an active and engaging conversation and welcome your questions throughout the program. Thank you again for joining us.
Hello, everyone. My name is Bennett Caughey. I'm a GI medical oncologist at Mass General Brigham Cancer Institute with a focus in colorectal cancers. Thank you for the invitation to speak today on this important topic. I'll be talking today about rethinking cancer risk in young adults, what colorectal cancer trends are telling us. First, I'm going to start out and talking just about the numbers, which are pretty dramatic, risk factors and causes we think are driving this, and then kind of ending with discussing what trends are telling us with a call to action. So first, by the numbers. Overall, when we think about colorectal cancer or CRC, it's actually really a story of success. If you look at the graph on the left, you can see that the rates of diagnosis increase generally with age. This is an age-associated cancer overall. And in 1995, the incidence at various ages was much higher than in 2022. We've seen a dramatic fall. And kind of on the right, we can see overall incidence as well as mortality has declined significantly over time. And this is attributed largely to screening improvements and implementation and improvements in colonoscopy, as well as improvements in treatment. However, the story is really the opposite when we think about young onset colorectal cancers or early onset, which I'll define here today as being less than 50 years old, although that sometimes those definitions are sometimes a little different. So when we look at the incidence across all ages, the incidence of especially localized diseases localized colorectal cancer has fallen significantly over time. However, in younger patients, the incidence has been steadily increasing, and this is particularly true for locally advanced, as represented by this kind of orange yellow line, and then metastatic disease as represented by by this red line. When we think about location, it's also kind of an inverse story. In all ages, and especially older patients, more proximal cancers are relatively more common. So that's represented by this green, and that's seen a dramatic decrease over time. However, in younger patients, more distal cancers, and particularly rectal cancers, as represented by the red line, as well as distal colon and sigmoid colon, represented by the blue and the dotted purple line, have seen dramatic increases, and with rectal cancers being by far the most prominent. And this has a lot of implications for how these patients are treated, as well as the long-term morbidity. especially as rectal cancers undergo different treatment, are much more likely to receive radiation into the pelvis, with many implications for the long-term care of these patients. Another sort of way of thinking about this, when we break it down by age and sort of extrapolate these things out, this top line is looking at the age 20 to 34 bracket, the sort of younger set of the early onset colorectal cancers. Rates are projected to increase by 90% from 2010. The rise is less dramatic, but still significant in the sort of 35 to 49 age group. And then in the older patients, 50 to 74, greater than 75, we're seeing actually quite a dramatic fall. And so more and more over these last decades, there's been this divergence in this story. I think there's a lot of way to look at these statistics, but overall, they're very sobering. Early onset colorectal cancers increased from about 7.9 incidence of 7.9 per 100,000 in 1988 to 13.1 per 100,000 in 2022. This is in the US, but I think globally this is being observed. But when we zero in at the sort of youngest patients, 2024, we're seeing the largest increase of 6.5-fold or 650%. You have a 400% increase risk of early onset colorectal cancer if you were born in the 1990s versus the 1960s. We sort of think about this as a kind of birth cohort effect. There seems to be, depending on kind of when you were born, the exposures at a young age, childhood, and as to a teenager, have increased the risk of being diagnosed with early onset colorectal cancer at basically below 50, younger than 50. Of that, we've seen rectal cancer has had the greatest increase by far, and overall these trends are expected to continue. There's steady increase in every year in the rates of diagnosis. And because of this, colorectal cancer is now a leading cause of cancer death in people aged 20 to 49. It is the number one cause of cancer death in men and number two in women after breast cancer. And because of this, the screening age was lowered to 45 in 2021 in the United States, and varying responses to this around the world. However, this doesn't really address patients who are younger than 45, which we still don't totally know what to do about those folks. This trend overall is international. It's kind of like a busy slide, but kind of meant to show kind of variation in various countries. The rise in early onset colorectal cancer was observed initially in Western countries, wealthy countries, those with kind of Western dietary patterns, but has since more recently been observed really across the world and also spreading into middle income countries, where this rise has been documented really all over the place. There are some places with actually decreases in ERCRC, which I'm not sure is super well explained, possibly changes in screening or more aggressive screening policies. But overall, the trend is kind of widespread. When we look at colorectal cancers and GI cancers in comparison to other early onset colorectal cancers, we can see that GI cancers have been increasing at the fastest rate in the last 10 years. From 2010 to 2019, the increase has been over 2%. However, other cancers have also been increasing, including cancers of the urinary system, the female reproductive system, and breast cancer. We have seen decreases in some cancers, and particularly cancers of the respiratory system, perhaps attributed to a decrease in smoking or exposure to certain kinds of air pollution. Within GI cancers, colorectal cancer very much dominates. We see by far the most cases in colorectal cancer in the early onset category. However, we are seeing increases in other cancers as well: stomach cancer, pancreatic cancer, small bowel cancers, esophageal cancers. Even though those numbers are small, they have been noticed to have been increasing in incidence in both men and women among patients less than 50. So this is likely a broader problem than just colorectal cancer, even if that's where the numbers are. I wanted to spend a moment focusing on some special considerations for the early onset colorectal cancer patients. This could obviously be a talk all by itself, but just to note that these patients do have very much a specific presentation, a specific biology. These patients tend to have a later diagnosis and come to attention later. And that's due to many factors. I think a tendency of patients to ignore as providers may not be as alert to certain symptoms in younger patients. And also, young patients, especially young men, are less likely to have health insurance, less likely to have a primary care physician. And all this leads to coming to attention later and being diagnosed at a later stage. We think that these cancers also have an aggressive biology. They receive more aggressive treatment overall. And that's also, what goes along with that is long-term side effects of the treatments that we give, which include things like neuropathy and the sort of side effects of pelvic irradiation for patients with rectal cancer, which is particularly important. One of those long-term side effects is late cancer risk. So, in particular, patients who receive pelvic irradiation have a risk of developing later cancers, which can take decades to manifest. That risk is overall pretty low, but it's a more important risk for, say, a 30-year-old than it is for a 70-year-old. Another very important factor for these patients is the psychosocial. I think fertility is often very top of mind. Many patients, particularly again, rectal cancer being very common here, rectal irradiation and rectal surgeries are much more likely to cause problems with conceiving and fertility, especially in women, but also in men. And again, especially for women, fertility considerations are complicated. Egg preservation is expensive. It's also time consuming, and it's not universally covered by insurance. And while this may not always be the first consideration for patients when they're initially diagnosed with a new cancer at a young age, it needs to be something that's addressed immediately. And we sometimes have to, if this is a priority, pursue fertility preservation even while delaying treatment, which is a really challenging choice to make. These patients also face body dysmorphia, changes in sexual function, which can be really, really challenging. Financial toxicity, again, many of these patients are not insured or also don't have a lot of financial reserve. And challenging family dynamics, or certainly different than an older patient. Many of these patients might have young children. Occasionally, patients are even diagnosed when pregnant, which is a particularly challenging scenario. So all of these really need to be taken account in a program that is taking care of these patients and really creates its own sets of challenges. Okay, so I'm going to move on to talk about risk factors and causes. This is a bit of a busy slide, but I'll sort of zoom in on some pieces of it individually. So first, I want to talk about sort of more non-modifiable risk factors, that are sort of well understood. I think the first is just family history and genetics. There are some cancer syndromes, the Lynch syndrome or FAP, that are strongly associated with early onset colorectal cancers. And this is always important to be thinking about for any patient who is diagnosed or if a patient may be at risk because of a family history. However, this really only accounts for a minority of cases. Certainly, we see more of these in the early onset than in sort of later onset patients, but it is really only accounts for a minority of cases. And it also has been stable over time, so it doesn't really account for the marked increase in early onset cancers that we've seen. Other kind of important things to think about are sort of inflammatory bowel disease as a driver for younger patients, age even within the young onset category, and then race and ethnicity. We see higher rates of early onset colorectal cancer in African Americans and Native Americans, but lower rates in Caucasians and Hispanics. I think another set of risk factors you might think of as more traditional modifiable risk factors, obesity and altered metabolism, things like diabetes, or diet. Many dietary factors have been associated with colon cancer and GI cancers in general, including red and processed meats, not enough fiber in fruits and vegetables, sort of an overall Western dietary pattern. You think about physical inactivity or sedentary lifestyle, as well as alcohol consumption and tobacco smoking. And these factors are associated with increased risk of colorectal cancer throughout a person's life and are, certainly important factors. However, I have to say that in my own practice, anecdotally, these don't really seem to be at the fore. I have many 30-year-olds in my clinic who are with colorectal cancer who have a normal body habitus, don't have diabetes, exercise every day, don't smoke, don't drink much, and yet they're still getting diagnosed with this cancer. So I've often, in my sort of perhaps more anecdotal experience felt like these explanations are lacking, even if they tell a story at the at the population level. And so I think that there's been an increasing focus on other explanations for why we're seeing this dramatic rise in early onset colorectal cancer. The a really one of probably the most important focus has now been on the sort of gut microbiome as a driver. We are increasingly understanding that patients who have colorectal cancer are more likely to have sort of what would call microbiome dysbiosis. So an increase in certain bacteria that that generate pathogenic factors that drive inflammation or DNA oxidative damage that lead to an oncogenic environment, as well as decreased diversity. There's also an increased understanding that the gut microbiome is a mediator of environmental impacts. So a lot of the things that are being eaten or things that people are being exposed to now are understood to alter the microbiome, and that may be the reason why they are driving associations with early onset colorectal cancer. Some really important things: early antibiotic use that seem to be driving this, Western dietary patterns, including ultra processed foods and high fructose corn syrup, things like that. Even in a person who maintains a healthy weight and exercises, these things still seem to cause microbiome dysbiosis. And then environmental exposures, microplastics and PFAs, which have been shown, especially in animal models, to be endocrine disruptors, to be pro-inflammatory. They're also maybe infecting the gut microbiome, and all of these things are now where we really think of as driving this rise in early onset CRC. I want to zoom in on the microbiome as a key mediator here. The Not to go through every piece of this slide, but there are many exposures that have been associated with alterations in their microbiome and also with early onset colorectal cancer. And the thing to emphasize is, that these exposures seem to start in infancy and continue throughout childhood, teenagehood, and then as an early adult, you may be reaping the consequences of that. I think a couple of things to highlight. One is just antibiotic use. I'm certainly a great believer in antibiotics, and support its use when necessary, but we know that there is antibiotic overprescribing, and we can see, one thing that's been associated with microbiome dysregulation, which makes some sense, is antibiotics as a young child, both below 2 years old, and of course throughout childhood. And antibiotic exposure is associated now with early onset colorectal cancer. So I think it's something that was not necessarily appreciated about antibiotic overprescribing, but now needs to be considered, in addition to many other exposures that are sort of driving this. I think another thing is kind of microplastics and other environmental contaminants that may be contributing to this phenomenon. I don't want to be hyperbolic about these. I think some of the causative relationships have not been fully established for all of these, but I think there's increasing concern about the presence of these in the environment and the effect on human health. And some of these might be, driving inflammation, oxidative stress, altered immune response, and changes in the gut microbiome, which then allow for a tumor-initiating environment, an oncogenic environment. So I think, we think of all these things as contributing to early onset colorectal cancer and colorectal cancer in general, but really, I think focusing on kind of this right-sided panel as what we think is the main driver of the market rise in early onset CRC recently. So I think, I'll move on to kind of what these trends are telling us. I think I've increasingly coming to think of the rise in early onset cancers, and colon cancer in particular, as near and dear to my heart, as a public health crisis. And it's one that is worsening. Every year we're seeing rise of multiple percent in these cancers, and the cost in mortality, morbidity, cost to the health system is just going to be increasing and increasingly, and needs a response. I think in the past, we've focused on a sort of traditional risk factor model. We might think of this as almost like the price of modernity, access to excess calories. We have less physical jobs, sit at our computers all day, access to vices like alcohol and tobacco. And, this sort of comes along with that. And I think part of that system, as much as society may shape how some of those things happen, also can place a sort of individual responsibility on patients. If you just exercise and watch what you eat, you'll be okay. And I think that that's very much kind of outdated in this kind of new understanding of why these cancers are happening, and requires a reframing. We need to think about how our society is structured as cause here, and how we are sort of designing our infrastructure and environment, how we're taking care of it. And that includes things like the food and the water supply, environmental degradation and contamination, and also health practices. So things like antibiotic overprescribing when not appropriate, as really having these long-term impacts. So I think in terms of some specific things that we want to be thinking about, on the patient care side, things that we are already doing but could continue to do better. One is education of both providers and the general population to recognize alarm symptoms, to take action rather than ignoring. Another is more personalized risk assessment. You certainly want to identify patients who might have a strong family history, and especially for patients who are younger than 45 who may not or not yet eligible for screening. We want to identify these patients, take good family histories, maybe more universal germline testing will become available. And then holistic health interventions also remain very important. So certainly encouraging exercise, improvement in diet, and quitting smoking, things like that all remain very important for people's health, both for preventing cancer, but also many other aspects. I think we also need a public policy response. I think this is both relatively urgent, but also very, very complex. How do we think about putting in place, policies at a national or even sort of international level that are, reducing these risks? Very, very difficult questions, but I think going to be an important part of actually combating this. And then, more research is urgently needed as well. These systems are incredibly complex. The way that the microbiome, which is made up of thousands of organisms, is interacting with our body and with the immune system to lead to cancer is not well understood, yet, and I think needs more and more focus. And so we're need to really thinking about mechanism and the kind of exposome, all the different things coming together to cause this. This biobank then involves large biobanking projects of stool, microbiome, and blood. We need to think about how we reverse dysbiosis to kind of fix these problems, think about early detection and risk assessment, really a focus on novel biomarkers that can help us understand why a 30-year-old might be at high risk versus another, and other methods of prevention and interception. So how can we catch something as a polyp before it turns into an advanced cancer? And many other things as well, but this kind of leaving just focusing on a limited list here. So I think in summary, I think of rising incidence of early onset colorectal cancer and other cancers as a public health crisis. I think the causes are both individual and societal, and gut microbiome dysbiosis is really what we think of now as a key mediator here. And a multi-pronged approach is needed to be tackling this as a society and as a health system. All right, and with that, I'll end. Thank you to Aparna Parikh for help with the presentation, and to the NCCN for the invitation. Thank you so much.
My name is Dr. Omalwala Salako. I'm a senior lecturer at the College of Medicine, University of Lagos, where I do my research and teach medical students. I'm a clinical oncologist at the Pearl Oncology Specialist Hospital, and I'm delighted to speak with you about a burning topic titled Delayed Diagnosis and Inequity. And the essence of our conversation today is to talk about the risk factors and the inequities young adults in low resource settings experience. So in today's NCCN Global Policy Webinar, our objectives are: the first is to establish a clear understanding of the adolescent and young adults oncology population, and just run through the global and regional statistics with particular focus on low resource settings. Secondly, we will evaluate the complex interplay of various risk factors that affect population. And lastly, we'll examine the various factors that contribute to the survival inequities common in low resource settings. I must tell you a story, one that hits home and one that happened 23 years ago. One of the reasons I became an oncologist was my younger sister, almost shown, pictured her on the right, 18 years old, when she had some vague symptoms, abdominal cramps, leg pain, and we thought it was related to her sickle cell crisis. And that went on for 2 to 3 months. Then we observed she started to lose weight. By the time she presented to the doctors in Nigeria, it wasn't clear what was happening. Then she proceeded to the United Kingdom, and there was about a 2 month delay before she was diagnosed. Eventually, when she was diagnosed, she started to see a specialist in a certain hospital. But one thing she said was, I don't like this hospital because there are too many women who are old gathered around me. I don't feel I belong here. And luckily, she was referred to another hospital that had, which is Middlesex Hospital, that had a teenage cancer trust unit. And in there, she was cared for about a month before she passed on. She was cared for with about 20 to 30 other young adults, and that made a huge difference, and that lifted her spirits, and she felt less alone. And so the definition of AYA is simply someone like Omosho who falls between the age of 15 and 39 years. For the first time, they are diagnosed with cancer. And that is such a unique time in a person's life where still in school or just out of school. They're in the workforce and in the early years of their workforce. They have limited savings. They may have health insurance coverage depending on where they originate from or what resources their country has. But really, in this age population, it is distinct. This entity of AYAs sits between the population of children living with cancer or diagnosed with cancer and the older adult group of geriatric cancers. So I'm trying to emphasize that AYAs develop different cancers. In my sister's case, she had renal cell carcinoma. Also, she had many unique needs, and it's important to appreciate that these needs may vary across spiritual, psychosocial, financial, treatment, and survivorship needs. Many more known faces who were diagnosed under 39 years of age, many more AYAs see on screen. But it's important to highlight them because they are heroes. For no reason, they have been diagnosed with cancer. Some of them speak loud about it, and some of them deal with it in silence. Many of them survive it in high-income countries. Unfortunately, many succumb to this disease in low-income countries. However, on a global landscape, I'm referring to data from 2019, AYA cancers represents the second leading cause of death in the non-communicable disease category. And in the low resource setting, it is the first leading cause of death. The global landscape and statistics on AYA cancers in the year 2022 highlights that more than 1,300,000 cases were reported, with the mortality rate of over 370,000 cases, and that roughly puts it at about 30% mortality rate. The age standardized incidence ratio falls at 40.3 per 100,000 cases. The age standardized mortality rate falls at 11.8 per 100,000 cases. I would like to highlight that females are disproportionately impacted in this age group, with more females being diagnosed than males. Globally, the most common cancers in the AYA population were breast cancer, followed by thyroid and cervical cancer, while the leading cause of death is breast, followed by cervical and leukemias. This image highlights different regions in the world, and I just want to highlight the survival inequities that occur based on geographical location and the HDI, the developmental index, according to different regions. So this image here, this is the continent of Africa, and Nigeria sits right in the center. The incidence rate of cancer in Nigeria is 6.4 to about 9.6. But if you compare it to the incidence in North America, which is way higher, it falls to over 53.3%. But if you move over to the mortality rate, you would see the survival gap. It is huge. So moving over to image B, which represents the mortality rate. Even though the incidence of AYA cancer in Nigeria is very low as compared to North America, it begins to mirror in mortality rate. And so in Nigeria, we have a higher mortality rate of 9.1 to about 28. And when compared to North America, the mortality rate is about 6.4 to 9.6. And this just highlights that the higher the incidence in the high HDI countries like North America, the lower the mortality rate, meaning more AYA cancer patients are surviving their cancers in developed countries. While in Africa and low resource settings, even though the incidence rate is way lower, the mortality matches to high income countries and sometimes surpasses the rates in high income countries. So there's a survival inequity that is huge, and it ranges across the low resource settings. Afghanistan, which is a war-torn country and has been unstable for a few years and decades, continues to rank, record very high mortality rate, particularly in the age group of 10 to 24. And, people between the ages of 10 to 24 represent a smaller cohort of the entire AYA population, followed closely by South America and Africa. And these are three countries, and Africa as a continent has a very high mortality rate from cancers in the age groups of 10 to 24. I would like to run through data collected from different low resource countries and the methods in which they collected data, the statistics that is emerging from this data being collected, as well as the clinical picture we're able to put together. In Nigeria, most of our data is collected by the Nigerian National System of Cancer Registries, which integrates its data from 15 specific registries, of which 8 are population-based and some are hospital-based. And what we are seeing for the AYA population is that the most common cancer is breast cancer, and it represents the age group between age 15 to 39. We understand the tumor biology of Nigerian cancer patients and women of African descent, particularly to affect younger women rather than older women, and particularly it also has an aggressive tumor biology characterized by late stage presentation and high growth. In Ethiopia, the data is collected by a population-based cancer registry and a hospital-based registry. And the most common cancer in the AYA population is leukemia, followed by nasopharyngeal cancer. And it's important to note that most of the leukemias are diagnosed and detected in the rural population compared to the urban locations or cities. And then we move on to another low resource setting, which is Bangladesh. And their data is collected and processed by the National Institute of Cancer Research and hospitals. And similar to Nigeria, Bangladesh's data is similar in terms of the most common cancer affecting the AYA population is breast cancer. And many of their patients present late, similar to Nigeria, and the late stage presentation can range from 6 months to 1 year. A lot of breast cancer patients continue to present in their late 20s and their 30s, and this is a picture that has transitioned over the decades. Cancers continue to evolve, and particularly for AYAs, we continue to see that the type of cancers they have are not necessarily in pattern with what we see for the older adult age group. Now, there are several risk factors linked to AYA cancer population, and the first is for females who are disproportionately impacted by cancer, and breast cancer being one of the most common cancers in this population. It's linked to hormonal fluctuations, particularly estrogen. There are inherited genetic syndromes such as BRCA mutations, Lynch, familial cancer syndromes that predispose AYA population to developing cancers. In certain regions of the low resource settings, there are endemic infections such as Epstein-Barr virus, human papillomavirus, HIV, and these viruses and infections do increase the risk of developing cancers. And so it is common to see infection-related cancers such as cervical cancer, which is linked to the human papillomavirus, HIV linked to Kaposi sarcoma. And most of the risk factors I have mentioned earlier, sometimes not within anyone's control, but there are risk factors that are controlled or can be controlled, one of which is the lifestyle and metabolic changes. And so with more people becoming obese, with more people not eating a balanced diet, they are exposed to poor nutrition, more people are experiencing sedentary lifestyle, reduced physical activity, and all of this increases the risk of developing cancer. The last risk factor I'll touch on is around the use of alcohol when it is heavily consumed, which is a social habit that is commonly picked up, and it is heavily consumed in the AYA age range. It does increase the risk of developing cancers. With tobacco being an immunosuppressant, and it contains over 300 chemicals known to induce the malignant process. As more people consume this, especially if they consume it from an early age, it increases the risk of developing cancers such as breast, colorectal cancers. In a decade-long study that we have collaborated between investigators in the Duke University, USA, and the College of Medicine, University of Lagos, we've studied about 500 breast cancer patients for unique risk factors, and the study is titled Mechanisms of Established and Novel Risk Factors in Women of African Descent. Typical of the data we are seeing nationally, most of our breast cancer patients have early onset breast cancer, the aggressive molecular subtype, which is triple negative breast cancer. But one of our new findings that is getting us excited is that the triple negative breast cancer cohort has a higher incidence of metabolic syndrome. Metabolic syndrome is made up of 5 clinical parameters, where there's a high glucose level or hypertension, a large abdominal circumference, high lipid profiles. And metabolic syndrome is established when there are 3 out of 5 parameters confirmed. And so for this cohort of triple negative breast cancers, which are known to be phenotypically aggressive, we are seeing that they have metabolic syndrome as one of the risk factors or possible force driving the aggressiveness of this cohort. It's important to highlight that we do have a lot of barriers that contribute to the high mortality rate in low resource settings. First off is there's a transition of epidemiological profiles. Between the ages of 15 to 39, there's a transition both in the incidence and the type of cancers this group experience. Secondly, in low resource settings, there are limited specialized infrastructure. For example, in Nigeria, there are less than 100 clinical radiation oncologists practicing in a country with over 200 million. And many low resource settings have even worse statistics. The AYA population is riddled with many socioeconomic barriers where they have limited financial savings or have limited health insurance or have reduced access to care. So when symptoms occur, they are not thinking it is cancer, and sometimes they are not presenting early enough. Secondly, when AYAs eventually present to the hospitals, the physicians, the last thing on their mind is it's a cancer. In low resource settings in Africa, for example, where there are swellings in the neck that appear as lymphadenopathy, the first differential diagnosis we think of are things related to tuberculosis rather than cancer. And so because there's a low incidence and there's a low exposure and presentation to the hospitals, we usually experience misdiagnosis and underdiagnosis of AYA cancers. Then comes to the point on treatment adherence. Cancer treatment is tough and it takes a whole lot to encourage someone in the AI population to get on treatment and stay on treatment. In many low resource settings where health insurance is limited and many people pay out of pocket, it's important to appreciate that many patients drop out of treatment because they can't afford it, because the families have to decide, do we spend all of our household income caring for one person, or do we use the same limited household income to do other things for the family, such as feeding, paying for accommodation for the entire family? And so many AYAs fall into that vulnerable population where they are dependent on many other people than themselves. And there's a long list of other systemic barriers in low resource settings. When we go into the healthcare systems, one of the top barrier is the lack of essential medicines required, the lack of diagnostic procedures required to diagnose and type and characterize leukemias that are common in the AYA group. Certain cancers, such as breast cancers, have more access, available diagnostics. However, they remain very expensive, remain unaffordable for most patients diagnosed with breast cancer. Another case study I would like to share with you is that of a cohort that was remotely monitored, and out of 205 cancer patients who were onboarded, recruited into a study where they were on active cancer treatment, either receiving chemotherapy or radiotherapy, about 25% of the total population were AYAs. And what we found about the disease distribution was breast cancer again ranked the highest type. It was the most common cancer type, followed closely by colorectal cancer. And this is to say that 25% of digital remote symptom monitoring study had AYAs, accounting for a quarter. And this is one way we can reach AYAs to improve their cancer literacy, their cancer IQ, encourage them so there can be better treatment adherence. Whilst there are many many barriers. There also are call to actions and low-hanging fruits that we can leverage for the AYA population. And it starts from top, where ministries of health, cancer stakeholders come together to identify and acknowledge this distinct group of adolescents and young adult oncology. It's important to develop trainings that allow primary healthcare staff who do the bulk of diagnosis, as well as all healthcare professionals, to have a high index of suspicion when an AYA comes or walks into the hospital with symptoms. They should have cancer as one of the differential diagnoses at the back of their minds, rather than eliminating it as a diagnosis in its entirety. A second call to action would be to ensure that there are cancer-specific protocols that suit the AYA population. With more women being diagnosed with breast cancer in their 30s, and in a situation where mammograms continue to be for women above 40 years old, we definitely are missing the diagnosis. The women are not eligible for diagnosis, but they eventually have breast cancer. And they may be dead before they get to the age of 40 when they become eligible. Secondly, colorectal cancer. And here in Nigeria, where colorectal cancer is one of the most common cancers in the AYA category, the Gastroenterology Association in Nigeria pushed for screening protocols to drop from 50 years old, to do a colonoscopy by 50 years old, and dropped it to 45 years old. And now there's a push to consider other alternatives for an earlier age. So we do have to respond to more sensitive and more sensible screening protocols that appeal to people between the ages 15 and 39, so that we can increase the diagnosis and initiate treatment immediately. It's important we meet AYAs where they are, which is digital. We can find them in the workplace as well as learning environment. It's critical we create engaging, educational, fun, colorful awareness materials that helps them understand that every AYA is at risk, regardless of location. And just that general foundational awareness in that age group will advance the awareness level. So it is saying that we should transfer the power to create awareness for AYAs to the AYAs, not only to the ministries of health, where you wouldn't find an AYA per se, not only to the primary healthcare centers where you may find them as doctors and nurses, but it's important to move the conversation to them. And AYAs predominate the digital space. So let AYAs who don't have cancer begin to understand that there are AYAs that have cancer, and there's a whole lot we can do raising awareness for them. The fourth call to action is moving pilot projects towards a policy-backed national digital health strategy. And this is speaking to closing the gap, delivering care, information, and education to the last mile. In many low-resource settings, AYAs are in the rural areas with limited infrastructure. It's important we develop digital health hubs in rural areas that provide the information and care, but most importantly, the navigation, so that when care or cancer care is required in a rural area that can't diagnose or treat, the digital health strategy navigates them to the closest place where they can receive the best care in their location. It's also important to target AYAs where they are. And for example, a great is in many universities, when AYAs are being enrolled, they're requested to do medical checkups. And that's an area where we can target education as much as inform them of risk factors, provide the health training, and teach them the steps they take to reduce their risk, and just the annual medical checkup they should access as they get older. For our Ministry of Health, it's important we design microinsurance schemes that support AYAs when they are diagnosed, and so that they are not extremely vulnerable when they are diagnosed and have no fund or access programs to lean on. Lastly, for us to say we are successful in the low resource setting, we must move away from talking about mortality rates, as I have talked so much about, to the time to diagnosis, reducing the 6 to 12 months delay that is rife in many low resource settings to 1 to 2 months at the most. But also for many AYAs that survive their cancers in high-income countries, that also has to translate to low-income countries. But most importantly, the life they live must be filled with quality. The late side effects must be tackled right at the beginning so that the risk of late side effects are reduced. Very much.
Hello, everyone, and welcome to the panel discussion. We just heard from Dr. Caughey and Dr. Salako, and I would like to welcome all our other panelists as well. Dr. Hovsepian, Dr. Perea, Ms. Samulovic, please could you briefly introduce yourselves and tell us what drives your work with young adults diagnosed with cancer, this growing big issue that we're all very worried about. I'll start with you, Dr. Hovsepian.
Hi, everyone. First of all, thank you very much for the invitation and thank you for organizing this important webinar. I'm really pleased to be the part of this discussion. So I'm Shushan Hovsepian. My background is pediatric oncology. I'm coming from Armenia, and I currently serve as the co-chair of Research and Innovation Working Group at PsyOp Global Health Network, and I'm also the Senior Vice President at OncoDaily, the global oncology platform. So my perspective comes from several angles: clinical oncology, global health, research, and communication as well. And I think that's really important when we are speaking about AYAs, because AYA is not only a medical issue, it's a system issue, survivorship issue, psychological issue, global health issue. And my interest in this field began during my fellowship in Milan, where I had the opportunity to work with Professor Andrea Ferrari, and I was at that time I was seeing many AYA patients, especially patients with sarcomas, and that was also my main clinical and research interest. And what struck me was that these young patients were facing challenges at every step of the cancer, starting from the diagnosis and referral pathways to treatment access, fertility preservation, ending with long-term reintegration into education, work, and society. And I also had the opportunity to observe activities and models of care specifically designed for this age group, and different countries, of course, have developed different models, but globally there is still no universally standardized approach. And so for me, all of these challenges made it clear that this is a field where we need stronger systems, better research, better communication, more advocacy, and that is what motivated me to become more involved in AYA oncology.
Yeah. Thank you. Thank you, Dr. Perea.
Hi, good afternoon here from Spain, from Madrid. I'm Jose Perea, I'm colorectal surgeon based in Madrid, and also I have this is my clinical practice, and also I have two different more perspective. One, I'm a researcher here also in Madrid in IMDEA Nutrition Research Institute in the Molecular Oncology Group, and also I'm starting a new position in Milan in Humanitas Research Hospital just in order to build the early onset colorectal cancer project, focus specifically not only in research, but also in all the things involved, the treatment, the diagnosis, and everything regarding early onset colorectal cancer in that center. So from that point, also I'm coordinator of two consortia. One is the Spanish Early Onset Colorectal Cancer Consortium. This is a prospective one, and also we started a few years ago because we think that early onset colorectal cancer specifically is a worldwide problem. We started an international consortium. This is the GeoCode, and is focused on the phenotypes around the world of early onset colorectal cancer. From that point, why I'm here or focused specifically on this subtype of colorectal cancer. So it was quite a long time ago, 20 years ago. I started my PhD work focused on colorectal cancer, younger than 45. But in that time, I was thinking, or all of us were thinking about that this was an hereditary problem. So I focused myself on Lynch syndrome, and in that investigation, we found the first finding was that the 80% of cases were not hereditary forms. So that was the starting point of this global effort around 20 years old.
Thank you. And Ms. Samulovich?
Hi, everyone. Pleasure to be here. I am joining from Pittsburgh, Pennsylvania. I bring a unique perspective to the conversation as I was diagnosed with acute lymphoblastic leukemia in 2005. I celebrated my 20th birthday 2 weeks later while still in the hospital receiving treatment. And as you all know, adolescent, young adult, AYA, even young adult cancer, none of that was a term back then. And so isolation was at the forefront, and I experienced it firsthand, which led me to continue to share my story with anyone that would listen, which then led me down the path of getting my bachelor's and master's in social work degrees. And I started building a community for young adult cancer patient survivors. I say survivors from day one. So when referencing them, that's what I mean. In 2012, I started facilitating support groups for young adults because we know isolation is one of the biggest challenges you experience first. And after facilitating support groups, I expanded and created a mission of providing emotional, social, and financial support, knowing that their needs are plenty, as we all have said so far, beyond medical. And so by 2019, I had built a community in our region here. In 2020, I launched Young Adult Survivors United, which is a nonprofit that quickly built a virtual platform thanks to the pandemic. And so we have in-person support here in our region, but also virtual support that spans across the United States to anyone who needs our support. We define young adults as diagnosed 18 to 45, and we offer a myriad of services. So I have become quite an advocate and quite a voice for this population. It also has led me to, I co-chair a community advisory board for UPMC Hillman Cancer Center. I sit on patient expert councils, and I'm honored to say that I serve as the advocate on the NCCN AYA guideline panel. So anything that's ever related to this population, I am at the forefront, just so passionate and honored to be here to share their perspectives and my own from a social work perspective to a survivor. So thank you for having me.
Thank you, Stephanie. Thank you for all the advocacy work you do and for being the reason we all are even here to do whatever we can to support people like you that are still fighting. Thank you. Dr. Caughey, I will turn to you first. Thank you for your great talk and summarizing the trends both in the US and the Western world and all over the world. Very concerning trends indeed. How have you changed your practice in treating these young adults as well as the older patients in your clinic? I know one of the questions in the chat also was, are rectal cancers responding differently?
Well, I think that's a good question. I mean, I think overall, we worry that among like early onset colorectal cancers may have more aggressive biology, maybe more likely to spread. They tend to be diagnosed a little bit later. Some of that may be a little bit anecdotal, and some of it may be certainly true or have biological basis, which is not completely understood. I will say that we think about these patients, certainly at Mass General Brigham, we treat them very aggressively, which I think leads to hard choices, because they tend to be able to tolerate more aggressive therapy, and we want to maximize our chances to cure for them, and so we kind of have that push there. And then at the other side of it, we worry about the long-term consequences for patients. So if we're thinking about decades of side effect, I think we're seeing so much rectal cancer, the potential for long-term ostomies or altered bowel function that can have a profound effect on patients' quality of life. And so I think increasingly that tension is at the forefront of kind of everything that we think about for patients. I think too, I really come to appreciate after I think several powerful experiences with particularly very young women, I think in particular, thinking through fertility and its role in the process and how to approach it is a very, very, very complex topic. Egg preservation in particular is very expensive. I mean, as I mentioned in my talk, and again, there's a lot to say about this, but I think fertility is very expensive. It requires a delay, and just as an anecdote, meeting a 23-year-old, and she's not even sure she wants children, and we have to have this conversation, and she wants to get started on treatment right away, and we're like, well, this may be important to you later. Is this something that we want to sort of pause to do? And it's really important that I remember, and it's part of our process, to bring that up really at the very first visit, even though that may be an incredibly overwhelming thing. And so I think with younger patients in particular, these kinds of factors come in, and I'm asking patients about, do you have young children at home? What kind of services can we be connecting you to? We're trying to be much more proactive around the isolation piece, as Stephanie was talking about, connecting patients to local resources, community groups, or sort of our own support groups. I think being really, especially proactive about all that is really important. I think it's true across the spectrum of colorectal cancer that we want to connect people to clinical trials. We want to explore kind of the maximum of the medical therapy that we can provide for them, which includes things like very aggressive surgeries. I sort of tell patients we don't want to leave anything on the table. And as much as we do think about that for all patients to a certain degree, I think it's just especially urgent for young patients. So yeah, I mean, I think, just thinking about bringing those kind of social concerns, I think, to the forefront, and thinking through, aggressive care and pairing that all together.
Wonderful. Thank you so much for that thoughtful and comprehensive, list of tips. And continuing on with the question of, isolation and how to deal with it, Dr. Salako, I was really moved to hear the story of your sister and how moving her to a different floor with younger patients really had an impact. Could you continue? You shared some in your talk. Could you continue on and share with us any specific measures that have been put in place in Nigeria or Sub-Saharan Africa for better education and better support for younger patients with cancer?
Thank you so much. I'm delighted to be here and grateful to be part of the panel. Across Sub-Saharan Africa, many governments, the ministries of health, are acutely aware of the cancer crisis. And it has become a priority for many governments. And the first areas they're tackling is around the public health education perspective. Now, there's also a lot of support from the cancer charities and medical associations to create culturally sensitive, wide language awareness materials, just so that the population is aware there's a whole lot of work that still needs to be done to get to that zone of cancer literacy and higher IQ that we haven't gotten to yet, because there are several cultural stigmas that continue to keep our patients out of hospital. In Nigeria, for example, 70% of patients still present very late with their disease. Even though we do have that aggressive tumor biology in our AYA population, there's also the increasing tendency for the younger population to present to the hospitals earlier than the older population. And this largely has to do with the education they are exposed to, as well as information that is online. I must also highlight the work of the cancer charities. Each country has a national cancer charity that is affiliated with its government, and there's a lot of advocacy movement coming from there. But there's also the cancer survivors who, as Stephanie said, from day one, they are rooting, they are speaking up, and they're telling their stories. They're bolder and they're telling the stories online. So it's, even though there's stigma, the younger population are not accepting that stigma. Also, in the cancer hospitals, many governments are investing, and we are seeing more public-private partnership hospitals springing up, global standard centers that are providing care. In Nigeria, for example, I'm one of 100 clinical oncologists, so it's really difficult to subspecialize just because the sheer number is too little to redistribute ourselves evenly into the subspecialties. But there are programs where we are now mentoring and training medical students to join the pipeline for oncology. It may take a few more decades, but across the different areas within the cancer care continuum, there are efforts. And lastly, it's the innovators who are also leveraging technology to get information across and just democratize access to accurate information.
Thank you, Dr. Salako. That's a great start. And as you pointed out, this is going to take a while. This is not something we can achieve overnight. I'll turn over to Dr. Perea. You know, the big question that we all have is, why is this happening so early and why is it so aggressive? Your own work and the work at your center has focused on understanding the molecular basis of this. So could you tell us biologically what is different?
So this is a very big question with a very, very, very extensive response, but I'll try to make it as summarized as I can. So firstly, I think that we are facing a unique subtype of cancers. That's the first thing. And from that point, we should think about that this is also not a homogeneous entity. There are different subtypes of these early onset cancers. For example, firstly, we have to think about the hereditary component. Of course, this is the main thing that we have to keep in mind, maybe facing in clinics. So from that point, this is a proportion that is continuously constant in order just to thinking about the trends that are rising nowadays. From that point, we have our group and other groups, we have made different comparisons between early onset colorectal cancer, particularly, and later onset. And from those perspectives, we have seen that, for example, thinking about the main carcinogenetic pathways, there are differences regarding early onset and later onset, and also the phenotypes, showing that maybe at least the influence is different. And also recently we have very, very innovative approaches. For example, there are some publications that are facing that a proportion of the cases of early onset colorectal cancer may show something like a mutation signatures in the tumors linked with colibactin and linked with Escherichia coli subtypes, for example. That is one of the things that this could be related with the alterations in microbiome, for example. Also, there are some approaches that are facing something like thinking about that maybe this specific individuals may have something like an accelerating aging in their body, maybe systemic, maybe in the colon, thinking about the possibility of a predisposition and then the continuous exposure during the lifetime. And finally, for example, and I think this is very interesting, we should think about that the relations with the immunometabolism alteration in those individuals. For example, recently we have published that thinking about the systemic immunosystemic response of early onset colorectal cancer individuals compared with later, the response and the subtypes of the immunocells are completely different. There are, for example, in early onset cases, some kind of chronic inflammation environmental, and also it is something like, it is not an immunodeficiency response, but partially yes. So these are very interesting approaches, and again, confirming that the first approach that we did, we think all the people that are involved in this subtype of cancer, that is that maybe should be a different entity. Finally, just as an example, and of course, thinking about the personalized medicine, there are some studies that now are showing that we should take on account the gender, because some biological and molecular profiles could be different if we think about women, female and male in this specific subtype of cancers. And it's logic, because if you think that women has fertility, the influence of the hormone should be doing something in the environmental that is different compared with males. And this is of course different if we think about later colorectal cancers, because in that sense the influence of the hormones, etc., should be completely different compared with early onset. So finally, I think summarizing, I think we have a lot of things moving ahead, but I think there is too much work to do. And of course, the effort should be multidisciplinary, and of course, thinking about the worldwide problem, that this should be an international effort, for example, like this webinar.
Thank you, Dr. Perea. And as you're speaking, I'm realizing the importance of biobanking and participation in clinical trials to allow materials for folks like you to investigate this, more thoroughly. I'll turn over to Stephanie, Ms. Samolovich. You know firsthand how unique this population is and all the different challenges that they face. What are the different most urgent gaps that you see that through your work, for example, in YASU, if I may call it that as a short form, are working on right now?
Thank you. I want to first say that I appreciate the multidisciplinary approach that's been highlighted a couple times, and also the importance of working with community organizations. We know from our perspective that the cancer centers and the hospital institutions can't do it all, right? And we don't expect that. So it is important to highlight that if we all continue to collaborate and work together and make the referrals when necessary, I think we're going to address the following urgent gaps that I identify and I see pretty much every day. But I think starting off, looking at the mental health support that's tailored for AYAs. In my past, I have referred our members, or survivors that I meet to a therapist, for example. And if it's not age related, age relevant, they're not understanding. When I tell you I can't make this stuff up, I had a patient who went to see a therapist who didn't recognize the term metastatic. So instantly there was a disconnect right there. So I think it's important when we're recognizing their needs to address their anxiety, their depression, their PTSD, when they're first diagnosed, the first thing we think of is, am I going to die? That's very traumatic. And then having to just disrupt your whole entire life right at the time when you're building it is pretty traumatic. Thinking about the fear of recurrence when they're going through treatment, your blinders are on, you're focused, it's a structured environment. You leave treatment nowadays, at least for us, you ring the bell and off you go. And then fear of recurrence is instant. So it's a celebratory moment when the outsiders, I will say, quote unquote, think that it's a celebration moment when you can move from a monthly follow-up appointment to 3 months, then to 6 months. But that instills a fear. a fear of recurrence, because within that gap, they don't know if the cancer is going to come back. So there's all these different age relevant topics that need to be addressed, but it's the therapists and the behavioral health clinics that need to address that and know what to expect. Talking about, as we've discussed, dating and intimacy, fertility concerns, career disruptions, parenting young children, body image, all those other things. And I think identifying their needs when you meet them where they are is also important. The majority of the time when I get a referral from a hospital, institution, or cancer center, it's for financial assistance, because that is an immediate urgent need. They can't work anymore, or their work is eliminated or paused or reduced, and they still have to keep up with day-to-day living and with their young kids, as we've mentioned too. So there's all these unique issues that arise and throughout the trajectory of the diagnosis and beyond into survivorship. And I think having the professionals to know how to address those best is very important. So through our organization, we provide, for example, free counseling with third-party providers that have the experience of supporting this population through our integrative oncology program, where we partner with providers and we cover the cost of the services just to help them with the offset of the financial burden. I think remembering still to this day, as I just said, the transition to survivorship, post-treatment is a very hard transition. Sometimes they need the support more than when they're first diagnosed and going through treatment. As I said, they're constantly monitored, they have a structure, they're receiving the attention and the reassurance. I still remember to this day when I was going through treatment, the treatment team becomes your family almost. You're there almost every day. You build the trust in them. You can rely on them, but then all of a sudden you don't see them nearly as much or at all anymore. So appointments drop, support decreases, and anxiety rises. So I think it's important to connect them with others who can relate so that they can say, this is how I did it. This is how I coped with it. And we are here to support your next phase of need and support. We talk about the peer connection and community just to that point. So we host in-person support groups as well as virtual support groups. We have evening chats, and we also have opportunities to connect during the day, during like a lunch hour, for example. And that's really where it's a safe place to just release everything that's going through your mind, whether it's cancer related or not. Sometimes there's other needs that they have to just talk about in a place and space where others can relate, but it's also facilitated by a professional or a trained advocate. We know that's also an important, because there's a lot of shared personalities, there's a lot of mental health being shared. So these are very sensitive conversations sometimes. So we have to know how to best navigate that when facilitating in a group conversation. We also know the importance that, and I saw this firsthand when I was building the community for 7 years, initially before launching this organization, that they can't just sit around and talk about cancer when they're already living it and trying to move on in life with hope of having a long-term life after cancer. So that's the only reason why we built a social component to it. So through our virtual social platform, we still are providing the connections, the education, but also giving them an opportunity to engage in a wellness activity. For example, a virtual bingo night, a virtual trivia night, a virtual guided paint night, where we ship all the supplies to their homes. So they're engaging in an activity while having these conversations too, if they want, but they know the common denominators in the room. They don't have to talk about cancer, but they certainly can if they need to share that conversation. And then I'll probably say this more than once, but the financial toxicity is probably among the most unmet needs, biggest challenges that we see. That is one of the resources that is not common enough. We probably know why. It's very complex. A lot of times people don't want to support that program as much as the others. But we at YASU, we provide grants annually to members. They can apply once a year for up to $750. And we pay directly to providers for rent assistance, mortgage assistance, utility bills, or in the form of groceries and gas gift cards. And the majority every single year is for the basic needs for groceries and gas. Trying to just get back into appointments or just put food on the table for their families. That's the hardest part sometimes that we're seeing, and that's what we're supporting the most. So I think when we all hear these examples that I'm sharing is, think about your cancer centers. What kind of refreshments are you providing on the table? Are they the kind that we think are leading to the cancer diagnoses? Are there sodas? Are there chips? You know, what kind of refreshments are out there? And I'll be the first to say, when I was in treatment, I didn't have a healthy diet because I just needed to eat what would keep my weight on. So having a variety, I think, is pretty important. You know, we try to educate our members on what food can you intake that is still healthy but cost effective. So trying to just keep all of that in mind is so very important. But we know that they have an elevated risk for long-term psychological distress across adulthood. So looking at all of these examples that I just shared are so important, and also why I think we still need to highlight the dietitians, the nutritionists, that if there's an integrative oncology clinic, for example, having us educate on the importance of that and see the benefits from that. But again, a multidisciplinary approach is always so important. And the last thing I will say here is, we can talk about raising the awareness, we can talk about the unmet needs, but as I announced the importance of advocacy, we have enough right now of this cancer patients and survivors that want to use their voices and that want to be in part of the conversations. So I think we always need to keep that as an important component when we are having these conversations, because without it, we think we know what's best and research can show things, but when you hear it from a patient perspective, boy, does it change the conversation sometimes.
Thank you. Thank you for that very comprehensive sort of, approach to the patient from the patient's voice. Dr. Hovsepian, I will turn to you, in resource limited places, especially given your experience both with pediatrics and AYA. What can we do to reduce the delays? Because I think these delays are hurting patients, and what is your opinion on what can we do to mitigate that?
Yeah, so that's a very important question. And first of all, we need to understand the factors that are influencing on the delayed diagnosis in young adults. And we should be careful here not to place the responsibility only on the patient or on the family. Of course, awareness matters, but in my opinion, diagnostic delays are usually the result of several system-level gaps happening together, especially in low middle-income countries. And the first barrier is that cancer is still perceived as uncommon in AYA, and when a teenager or young adult presents with pain, fatigue, weight loss, and some symptoms that are not specific, it may be attributed to infection, stress, sport injury, and so the first delay can happen at the level of recognition by the patient, the family, and sometimes even with the first healthcare provider. The second barrier is the biology and presentation, which has already been mentioned, and we know that AYAs have a very diverse cancer spectrum. They can develop cancers that are more typical of childhood or more typical of adulthood, and including like thyroid, breast, colorectal, melanoma. Because the spectrum is so heterogeneous, there is no single AYA cancer pattern that every physician immediately recognizes. And AYAs have a cancer spectrum that occurs at no other age and has been less studied than cancers in younger children or older adults, and this contributes to uncertainty in how these patients are evaluated and referred. And here we need education and awareness for the first healthcare providers, especially, and I'm highlighting this again, that especially in low middle income countries. There is also the barrier of fragmentation between pediatric and adult systems. AYAs often sit between services, and depending on their age, tumor type, hospital, country, and they may be seen in pediatric oncology, adult oncology, surgery, orthopedics. And if referral pathways are not clear, the patient can move from one service to another before reaching the correct specialist. And that would delay the diagnosis again because of the system and because of the referral pathways. There is also limited access to specialized centers. This is particularly important in this field because the tumors are rare, and these diseases often require multidisciplinary evaluation, expert pathology review, imaging, molecular diagnosis, surgery, radiotherapy, and this is not available sometimes in low middle income countries. And if a young person is first managed in a setting without this expertise, diagnosis may be slower or incomplete. And that will, of course, impact on the outcome. And in resource-limited settings, these barriers become much more severe, and the problem is not only late recognition, it is also limited diagnostic capacity. There may be few population-based cancer registries, limited pathology services, limited imaging, molecular diagnostics, and which are important for the specific tumor types that are occurring in AYA age group. And Blair and colleagues specifically mentioned that in many low middle income countries, diagnosis is compounded by misdiagnosis and leading to poor outcomes, and delayed presentation can mean that patients arrive with an advanced disease, and in some settings, abandonment of therapy remains a major problem as well. So the same delay looks different depending on the setting. In high income setting, the delay may be more about fragmentation, low suspicion, lack of AYA specific referral pathways, or being treated outside an expert center. But in low middle income countries, the delay is often more structural. The patient may not reach to the system early, the system may not have the tools to diagnose quickly, or the family may not have the financial or geographic ability to continue evaluation and treatment. For example, a young adult with a sarcoma may initially be treated for sport injury or benign swelling for months, for years even. In a well-resourced system, the delay may be weeks or months before referral to orthopedic oncology. And in a resource-limited setting, yeah, it is a huge problem. No MRI nearby, no expert biopsy, no sarcoma pathologist, no radiotherapy access. So by the time the diagnosis is confirmed, the disease may be more advanced and the treatment options more limited. For me, the solution has to be multi-layered. We need better awareness among primary care physicians, pediatricians, emergency doctors. We need clearer referral pathways for persistent unexplained symptoms. We need AYA sensitive navigation as well, so young people do not get lost between services. And globally, we need investment in diagnostic infrastructure, pathology, imaging, registries, and specialized multidisciplinary care. And the key message here is that delayed diagnosis in AYA cancer is rarely just one missed appointment or one missed symptom. It is usually a signal that the system was not designed around the realities of young people. And if we want earlier diagnosis, we need systems that recognize young people faster, refer them smarter, and support them from the first point of contact.
Thank you, Shashank. You bring some very, very important points. Listening to your patient is key, and fighting not just for them, but also to change the system and adapt the system to meet their needs is what we all should be thinking about. And you make some very good points for education for primary care doctors, ERs, and other places, even orthopedic doctors, it sounds like, everybody, and some important work that needs to be done. Dr. Kay, there have been some questions in the chat as well on this topic. Are we ready to intensify therapy or change or personalize therapy for young adults yet?
I think the probably the short answer to that question is no. I think there is, a recognition that these tumors are different, but it's kind of hard to tell outside of the research setting how they're different. Outside of inherited syndromes being enriched in young patients, and they can very much get a personalized approach. That remains the minority, and I think many of the in colorectal cancers, which is my focus. I think I'll just give the caveat that I think especially like breast cancer, which I don't actively treat right now, may have some different thoughts around there, but. We, for example, don't really see strikingly different like molecular patterns that, or at least not in the sort of main genes that tend to kind of guide our management or tell us kind of what to do, what when. And the distribution of cancers is somewhat different in that we see more like rectal cancers than more proximal cancers, but we just treat them like we know how to treat rectal cancers. I think one thing that this may be partly institutional here, and I was typing an answer actually related to this. We certainly at MGB have err on the side of treating these young patients aggressively. And I think some of that, if I'm being really honest, is probably a little bit emotional. You know, we connect strongly with these patients, and we can't bear the thought of that we err on the side of making sure, you know, we don't leave any 1% of cure on the table. And I think that's not always the mentality for older patients, where we're thinking of maybe about a more balanced approach, or we should. And but there isn't necessarily strong evidence that that is helpful. At the same time, we don't want to undertreat patients either. And I think that creates a really difficult tension. And I don't think we have like a refined or nuanced biomarkers that are allow us to treat, you know, a 35-year-old substantially different than a 65-year-old. And I hope that may change. You know, I think if we, you know, there may be like more sort of transcriptomic profiles that can guide us, for example, that are different than sort of our more routine sort of next generation sequencing panels, and or pathological predictors of aggressiveness, you know, things like, you know, spectrum of differentiation. So I think there's always more to be done here. And I think increasingly, you know, there's one question about other guidelines different. I don't think they are, but I think maybe we should get to that point if we can learn more about how better to treat these patients.
Thank you. Thank you. Dr. Salako, I'll pick on you for one more question here, you know, specific to stigma in the, you know, Nigeria, in the African sub-Saharan region, especially with cervical cancer, breast cancer. How are you tackling that, especially in this population?
It's just that continuous awareness and push that certain cancers are preventable, and we shouldn't be dealing with those preventable cancers like cervical cancers, and just tackling the endemic infections like hepatitis B and C, HIVs, and the chronic infection with human papillomavirus. So at a community level, it's that one-on-one engagement, and of course group engagement with the public, and meeting them where they are in the religious institutions, their learning environments, and the informal gatherings, and just getting them to be aware so that they can take informed decisions towards their healthcare. There's still a low acceptance of cancer screening, and this borders around how close the services are to the public, to the populace, especially for millions of Nigerians. They are in the rural areas, and there are scarce cancer screening services. So people have to travel for very long distances and spend a lot, and that gives them a choice sometimes. So that continuous conversation, and just generally speaking, me being part of this panel is highlighting the need for me to go back to my own medical community to say, we do agree, our data and our clinics show that we are seeing younger faces over the last 2 decades. Now, what are we doing about this? So webinars like this also spur action and, you know, intensify the conversation. On the other hand, my research will continue to focus on the novel risk factors we are trying to identify, what is fueling the aggressive nature of cancers. There are some established factors that align with the low resource settings and the high resource settings, but there are also some risk factors and the way our patients respond to treatment that are not aligned. And so we have to ask ourselves the right questions, conduct indigenous research that serves our communities and the global cancer community. And just generally encouraging more people to work within the cancer workforce, not only in the clinical setting, which is the greatest need, but also in the business setting. We need more healthcare leaders, more business-minded people to set up cancer centers, run accelerators, you know, more scientists going into research, having more molecular biologists, so that we can actually begin to build better infrastructures when it comes to things like the biobanks, for example. The few biobanks in our country are powered by research, and we have very limited findings coming out, but very important and critical. But we do need more innovators, taking the lead to create digital products, integrate AI, build models that are specific to our indigenous cancer research data. And the last thing would just be around actually beginning to create and design programs, conducting needs assessment first amongst the existing AYA. And I remember one of the remote symptom monitoring studies we did, we asked the population who were the first early adopters why they used the remote symptom monitoring tool. And I remember a specific participant saying, I just want to contribute to research. And that's type of lingo is something that is not very, very common. People do it for different reasons, but just to find out why they are going through this is something that a typical AYA would say. So just that need to sit with the AYA population in low resource settings, talk to them and understand where they're thinking, what we can do to improve accessing them, and how we can solve this problem is something we all just need to continue working on.
Thank you. Thank you so much. I'll turn to you, Dr. Perea. How strong is the evidence linking environmental exposures, diet, sedentary behavior, or endocrine, related chemicals in this rise that we are seeing, especially since these are global trends? I would imagine some of these things, we touched upon gender briefly, but environment and microbiome, I would imagine, are different. What is the evidence?
Oh yes, and some of them are already related with the colorectal cancer, for example, as a whole. For example, diet, sedentary life. But we should think differentially, I think, and then from that perspective, for example, putting in one side predisposition and one side environmental, I think the cohort effect that has been a few years ago seen regarding the trends in the incidence is very interesting, because now, for example, in the USA, it's being seen that, for example, it is not the incidence of people younger than 45, 50, but also 55 and also 60 are increasing. Thinking about that, there is something happening from the 60s and 70s, and from that point has changed. So, of course, the factor of environmental, I think, is a key important principle in that sense. From that point, there are some interesting findings they published last years. For example, those are indirect findings, but I think are very related with exposures and environmental. For example, recently, a work published by a Spanish group based in Barcelona linked early onset colorectal cancer, not only colon but also rectal, related with some methylation signatures about pesticides. And it's very interesting in that sense that it could be related, because they compare early and later onset, and they saw that there were more frequently those signatures in the individuals younger than 50. From that point also, the mutation signatures linked with colibactin, for example, we don't know whether there are cause and consequence in some cases, but the signatures is over there, and is more frequently in some cases, for example, in South America and in Canada, etc. So again, the environmental should have a role in that sense. And finally, the last hypothesis about accelerating aging, of course, I think that the exposure should be a key important factor. So what should we think about in the future? So I think one of the most important things are think about cohort studies, long follow-up cohort studies from the birth along, for example, 40 years, 50 years. It's very difficult to make them, but I think it's important to think about, and of course internationally, because in that sense we will see the influence according to the geographical side about the environmental factors that could be related with early onset colorectal cancer. So in that sense, again, think about the disparities worldwide is important to keep in mind. And finally, I think it's very interesting because this is a global problem, and of course in the USA, in order just to make the screening of early onset colorectal cancer more successful, the cutoff age has decreased from 50 to 45 and is thinking to be 40, but for example, this is not feasible in other sides of the globe. For example, I don't know, LATAM. For example, I'm thinking LATAM because I know all the countries, also Europe, because there are so many heterogeneous factors that it is very difficult to try to define a specific cutoff age. So maybe in that regards, we should think about firstly try to define biomarkers that could define which individuals could in the future develop or are in risk to develop early onset cancers, just to make specific screening programs for that subpopulation and not in general. That's maybe could be another approach.
That's wonderful, Dr. Pereira, giving us some great ideas here for our listeners who are designing clinical trials to store biosamples for this kind of work, and also build in some very long-term follow-up for these individuals. And I know some of the questions have come in the chat as well, asking about guideline concordant care and to inform us on whether patients should be getting more intensified therapies or less intense therapies or having different toxicities. Just having publications and measuring that would be important. As we draw to an end here, I want us to end. I know these have all been very sobering statistics and facts and figures. I'll go around the entire panel here and ask each of you to, in a minute or so, share with us, what is going on in your world that makes you feel hopeful for this population. So I'll start with you, Dr. Josepan. Would you like to end with a hopeful note and share with us something that you're excited about or hopeful about?
Yeah, so, well, as I mentioned, the problem and the challenges are a lot here, and we need multi-layer approach. And looking ahead, what gives me the most hope is not one single discovery, but the shift towards integrated networks or expertise. And one of the examples could be the project like JANE, the European Joint Action of Networks of Expertise. And we know that early onset cancers are complex and they are not explained by one factor. And the projects like JANE is so relevant, that's created to shape different networks, and including personalized primary prevention, survivorship, palliative care, omic technologies, high-tech medical resources, complex and poor prognosis cancers, and young adults with cancers. Its goal is to prepare these networks and evaluate how European cancer networks can function more effectively. And if we have such kind of projects in every region globally, hopefully we will come one step forward to the solution of the challenges that we are facing and AYA patients are facing. In my region specifically, we don't have system integrated at this point, sadly. But I think for the low middle income countries, the key point would be to have AYA navigator or multidisciplinary team at least that will communicate with each other, even though they are limited resources, but the communication within the different settings would be the key to have most effective cancer diagnosis and care for AYA patients. And So my hopeful answer is that the future is not only a new biomarker or new screening test, it is a coordinated learning system where prevention, molecular science, clinical care, survivorship, everything are connected. And if networks become sustainable and truly inclusive, they can help us move from reacting to early onset cancers to understanding them earlier and preventing what can be prevented and treating young people better when cancer occurs.
Oh, that's so wonderful. And Dr. Caughey?
Yeah, I certainly agree with all that. Very well said. I guess I'll mention, I think, I feel like I often tell people I feel like we live in a golden age of, biotechnology and cancer discovery. I think the pace of the field from a treatment and just like the tools that we have access to have just been moving forward at a tremendous rate. While I think prevention and just reducing environmental and exposure would be, very ideal here, I also think that we are making tremendous strides in, treating cancers. And I have a lot of optimism, certainly in my own field and in the coming years, even if patients are diagnosed, our rates of cure, our rates of treating people without the need for life-altering surgeries, is increasingly possible, and that that obviously requires access to those technologies and requires distribution of those technologies. But I'm increasingly hopeful that that's true. And I would also say there's increasing focus on this in the field, increasing mobilization of biobanking resources, and the technologies that are available to 10 years ago would not have been able to handle the complexity of the microbiome, integrated with the immune system, integrated with all the things with the cancer itself, thinking about single cell transcriptomics, and just all these different things that we have that have enabled us to sort of examine the complexity of the system to better understand it. I think we'll get there with all of this that's in play.
Thank you. Dr. Salako?
I'm hopeful that 3 points I'll share would, help bring some light and more rainbows into the situation. And the first would be how we advance with clinical trials, with more clinical trials specific to the AYA population. We would have a chance at finding a discovery that will make a huge difference. Clinical trials that are inclusive, representative of the entire globe will make the most difference and the best return on investment. The second point will just be around AI. Very quickly, we may get our answers with the use of AI to build models to comb through retrospective data and, most importantly, current data. And the third would just be to democratize the public health education and transfer the power of educating people about AYA cancers to the AYA population. If we can find a coordinated movement online that talks about AYA cancers, and the people at the front of this talk and conversation are people within the age of 15 to 39 years, I feel they would demand better and get a global movement and just get all the scientists, the policymakers to focus on this niche group. And I think that would cut the time to finding the answers shorter if the AYAs are at the head of the topic. Thank you.
Wonderful. Dr. Pereira?
Thank you very much. Just very briefly, I want to arise two things. Firstly, again, I think that this problem is a multidimensional, multidisciplinary problem. We are involved, clinicians, basic researchers, patients, all the society. So this is very important, and also a global problem. And one of the best examples is here. We are now in a live webinar and talking about this problem worldwide. So I think this is very, very important and interesting. But this is maybe one of the first steps And then we should continue. And also, I think one of the most important things is we should advocate, we should make all the people conscious that this is a current problem nowadays for everybody, and in all the dimensions. I mean, for the clinicians, also the general practitioners think about this problem, social politicians, in order just to make screening programs, etc., and everybody just to again erase the importance of the problems, because if we gain that point, then we should move very, I think, easier in order to find the clue of the problem.
Thank you. And last, Dr. Ms. Samulovich, any comments from you, closing remarks on why we should stay hopeful?
Well, we should stay hopeful because, as I've seen over the years, more conversations like this are being had. This was never a topic when having discussions about oncology care or the populations that were served or the unmet needs. So I think it's really exciting to continue to put these conversations on the forefront. And I think I am hopeful that as we continue to raise the awareness and bring up the topics like this today, we can then put in actionable plans. We all know there's an overwhelming amount of a to-do list, if you will. But I think if we not only compartmentalize where we can best serve, we can also collaborate on those who are doing it even better or have an established program to then work together on, to then enhance the support programs that are being offered. And I think that I always have to say, to continue to keep the importance of having psychosocial care and these conversations, making sure mental health is just as equally as important as the physical health when we're talking to the patients and identifying their needs. So I just think that we, it is a global problem right now. We can globally work together to continue ironing out where the needs are remaining and how we can all work together to fill those gaps.
Thank you. Thank you so much. And for each of the participants for your work in the space and for your thoughtful, remarks today. Thank you to all the participants and the team organizing this program. In conclusion, from our experts, we have learned that recognizing that this is a problem and talking about it like we are doing today is step one, putting efforts to coordinate care for these young adults who are just learning how to be adults and sometimes are transitioning from a pediatric doctor to an adult doctor, just figuring out life, the support they need, the mental health support they need, the financial support they need. Coordinating all of that is important, and that rests on all of us to create the systems for it. It was great to hear, Dr. Salako, of the many things you've already accomplished using digital tools, and your points are very well taken, transferring the power of that education to them, harnessing everything that we have in the social media space, AI space, digital world that we're in would be very, very helpful. And giving some of those biospecimens and clinical data, gathering guideline concordant material information, both Dr. Caughey, Dr. Pereira, your work in that space, in the clinical space, in the lab space, and publishing that work, getting that out, especially for the screening to primary care doctors, the people who really need to know it to mitigate the delays, are all things that we need to work on. And we will put that work on our to-do list, all of us that are in this space. And I will, with that, thank you all once again and turn it over to Matt Izzo, my partner here in Global, to make some closing remarks. Thank you all.
Hello, everyone. My name is Matt Izzo. I'm a specialist in the Global Policy and Strategic Alliances at NCCN. I want to thank you all today for your time and your attention. Next slide, please. I would also like to recognize the following supporters. Without your continued support, it would not be possible to have these really important conversations. So I would like to thank you as well. And please note that the second iteration of the webinar series focusing on oncology workforce shortages and the future of cancer care will take place on November 5th of this year. So more information will be sent about that soon. And with that, I would also like to thank our panelists and presenters, our moderator, Dr. Iyer, as well as Stephanie Montesino from Global, Mark Geisler, Mike Abrams, and Liz Reeder from Meetings. Without all of you, this would not have been possible. So thank you again, and everyone have a great rest of your day. The webinar recordings will be available on nccn.org Global Policy page. Thank you.